Welcome everyone to today's session of our Blum Survivorship Pelvic Radiation Treatment and Side Effects, led by Betty Kretschmer. This program is hosted by the Blum Resource Center. Over at the Blum, we are grateful to the survivorship team for this continued partnership. The recording of this session will be posted on our Blum YouTube playlist and our Blum Digital Resource Center. If you have any questions or would like more information about resources and programs offered through the Blum, please visit our website at www.dana-farber.org/resource center or email us at blum_center@dfci.harvard.edu. Thank you all for joining us. I will now pass the workshop over to you, Betty.
Thanks, Sarah. So my name is Betty Kretschmer, and I am a PA, and I work in radiation oncology here at Brigham and Women's Dana-Farber. I specialize in gynecological radiation oncology, and this presentation was made with my coworker, Abby Saranteas, who unfortunately couldn't be here today, and she specializes in GI and GU in radiation oncology. So today I wanted to talk about pelvic radiation treatment and side effects, and I'm going to go over a little bit of background of what is radiation, how radiation is performed, some of the details about if you or your loved one has gone through radiation, what that is, what to expect if you are going to go through it. So I'm going to go over a little of that and then talk a little bit more about some side effects in the short term and long term, some ways that we manage these side effects, some modalities we're doing and things to reduce side effects in the future, and a couple other things in there. So, all right, so what is radiation? Radiation uses beams of energy like X-rays to target and destroy cancer cells. Radiation works by damaging the DNA of cancer cells, which prevents them from growing and dividing. The cancerous cells are generally more, it's more difficult for them to recover when they are disrupted and damaged by the radiation. And this causes them to be more vulnerable to cell death. While healthy cells are also affected in these areas that are being treated, they're generally better at repairing their DNA, which allows them to recover in between these radiation doses. Organs close to the treatment field may be affected, which can lead to side effects. So for example, if we're treating the prostate with radiation, the bladder and rectum will also receive radiation dose. So as many people may be aware, if you or someone you know has had radiation to the pelvis, there's many organs in that area. So even if you're being treated for one specific disease site, the other organs in that area are likely going to get some dose, which can be the cause of other side effects. There are multiple types of radiation therapy, and your radiation oncologist will decide what treatment approach is best for you. So this is called a linear accelerator. This is an example of the treatment machine that you are on when you're receiving radiation treatment. So that kind of machine part above the patient actually rotates around the patient to deliver those beams that we talked about in the last slide. So this is a very specific setup that each patient will have on these machines. So this is, and we'll talk a little bit more about how this is set up, but the patient is really set up in the same exact position each time that they're going to have their radiation treatment. So this is an example of somebody lying flat on their back, but depending on the area that we're treating, the patient may be actually lying on their stomach, their legs could be frog-legged. It just depends on the best treatment position for the patient based on where we're treating and their anatomy. So this would be set up with the patient so that the patient knows at this the first time they go what their position would be for every subsequent treatment. So what do we use radiation for? Radiation therapy can be used for a number of reasons, often to achieve a cure of cancer. Prolonging survival is another reason we use it. And it can also be used for palliation of symptoms. So it can be used for pain or bleeding in certain situations as well. What can we radiate? This is a long list, but essentially we can radiate many sites in the body. And again, this can be from different treatment modalities, but we can radiate a lot of areas of the body, and especially in the pelvis, we can radiate most locations. So radiation is very personalized. It's not a one size fits all. So when somebody is going, the plan is for them to receive radiation and they meet with their radiation oncologist. This plan is developed individually based on a multitude of factors. So these factors will include the patient's anatomy, and this can be done through an exam. Often the patient has had imaging, so a CAT scans or PET CTs or MRIs, and this helps us look at the patient's anatomy, also the size and location of the tumor, the pathology of the tumor. Some patients have had surgery, so this is also a factor, and sometimes the pathology just comes from a biopsy. Concurrent treatments, so many of our patients on radiation are also receiving other treatments such as immunotherapy or chemotherapy, hormonal therapy. So those are all factors in our radiation dosing and planning as well. The patient goals of care, of course, is always something that we keep in mind for these treatments. And then the treatment modalities available based on geographic location. So we'll talk a little bit more about the different types of treatment modalities in a bit, but some of these treatment modalities are not available based on the hospital that the patient is presenting at or in different parts of the country and the world. Patient and treatment variation. So although if somebody has one type of cancer and knows someone who has the same type of cancer, the treatment and side effects can vary significantly for each patient. So like we just talked about, all of those different factors are taken into consideration when we're developing a treatment plan. So two people who may have a similar type of cancer may have a very different treatment. We don't know exactly why certain patients tolerate treatment better than others, even if two patients did have a same or similar treatment. There are some factors that are linked to how patients tolerate treatment, and that is age, overall health, and other medical comorbidities. But that being said, there can be patients who have gone through the same exact treatment and someone does very well and has minimal side effects, and someone else has significant side effects. And we don't know a lot about why that can happen. So what happens when a patient gets radiation? So they'll have a consultation with their radiation oncologist. After that, they'll have a simulation or a planning session. So that will look like that picture earlier that I showed on that linear accelerator where the patient is being set up there. So that's when the patient would get information on how they'll be positioned and more about what their treatments every day will look like. After that is planned with the patient there, behind the scenes, there will be a lot of other things that go on after the patient leaves. So there's a treatment planning and a physics check and a quality insurance check on the treatment machine before the patient comes back for their first treatment. So these things behind the scenes where the radiation is being planned can take anywhere from 1 day to even 1 week. And sometimes there's more urgent cases that we can do a little bit faster, or simpler cases, and something more complex could take a while. After that plan is solidified, the patient would have a start date for treatment. Usually the patient will show up their first day of treatment and then receive the rest of their schedule for their upcoming treatments. While the patient is undergoing treatment, typically they'll see their physician and nursing team at least once a week. And that's to just check on the patient, make sure that they're tolerating treatment well, and deal with any side effects as they start to happen throughout treatment. After radiation's over, typically patients are followed in a follow-up clinic, and that can be for many years. So part of this radiation planning process, the physicians will outline the tumor that they plan to treat, in addition to critical structures around that area that they want to avoid. So this is used using imaging that we've taken of the patient. So this would be from generally a CAT scan or an MRI. The dosimetrist will create the treatment plan. So this is deciding how much dose from each angle the radiation is delivering to the patient and where it's going. The medical physicists will ensure the dose calculations are correct. that the radiation plan transfers from the computer to the machine correctly, and then they'll perform a safety check like we talked about on that machine. And again, the process can be very quick, one day, or can go up to 1 week, depending on how complex the case is. So treatments. Patients may receive as few as one treatment and up to 30 or more treatments. This again depends on all of those factors that we talked about earlier, what we're treating, why we're treating it, what treatment we're using. The treatments are typically daily, so patients will typically come to our department every day, once a day for these treatments, and they don't receive treatments on weekends, so it's Monday through Friday schedule. Patients typically don't feel anything when those beams are on with those radiation treatments. Patients are in the room alone with a camera and a microphone while those treatments are on. That's just to keep the rest of the staff safe and not expose them to any unnecessary radiation. But the treatment machine can be stopped at any time from the outside where the staff is. So this is just an example to show you what that plan behind the scenes look like. So this is a pelvic field. And as you can see, all of these circles are exactly what the physician and the dosimetrist and the physicist work on behind the scenes. So this is drawing the structures. And these colors here are associated with these numbers on the left. And that's actually the doses of radiation that these areas are receiving. So we often use this to know exactly what we're treating, of course, and how much dose each area is getting. In terms of side effects and things in the future, this is something that we refer back to often. We can, if a patient has symptoms, we can kind of look at see how much radiation dose that area got. And if there's a patient has something going on in that area really didn't receive any radiation dose, we know that it's likely not a late side effect of the radiation therapy. So I thought this was just interesting to look at to see how much goes in behind the scenes and how these plans are made. So there's been steady progress in cancer advances over time, and this has led to increasing cancer survivors over time. According to the American Cancer Society, in 2002, there was an estimated 18.1 million cancer survivors, and that's expected to increase to 26 million by 2040. As you can see in this graph here, that there are a large number of cancer survivors for prostate, colorectal, and gynecologic. So these are all pelvic radiation fields. So this is really important that we're knowing how people over time what kind of side effects they're having from this radiation to the pelvis and how we manage it over time. This is a study out of the University of Oxford in 2014. This was a questionnaire for cancer survivors who had pelvic radiation 1 to 11 years previously. So this reported their toxicity, their psychological morbidity, and their quality of life. And it was found that patients who had ongoing long-term symptoms or side effects from treatment was associated with a poorer overall quality of life. So we know that late effects from pelvic radiation are common among long-term cancer survivors, and healthcare professionals need to pay close attention to this during follow-up care and need to be adequately informed on the most appropriate management strategies for these patients. So typically, this is just some images of 2 patients who received treatment for rectal cancer. So these 2 patients had a different course of treatment and also had different radiation fields. So again, just emphasizing that there are, can be different side effects based on someone with the same diagnosis, but or a similar diagnosis and have a different treatment plan. Generally, the more radiation the patient receives, the higher risk they are at developing side effects. That's for the short term and the long term. Side effects will typically worsen over the course of the treatment. So sometimes if patients are receiving 30 fractions of radiation, so the first couple weeks, they won't have any side effects. And as the treatment goes on, the side effects will worsen. Generally, for a lot of patients, the side effects will continue for a week or two after they finish radiation. And then generally they'll start to get better there on out. So the timeline in which the symptoms get better can vary a lot among patients, and we really need to follow patients closely over time to make sure that those symptoms are getting better. And when they're not, or they're not to a level of a good quality of life for the patient, we need to be addressing them. So that is something that we really need to have a close relationship to follow patients over time and make sure that we know what's going on in terms of side effects. So I'm going to go through some side effects that are common or that we know about in pelvic radiation. So with every treatment, of course, there's a long list of potential side effects for patients that you receive when you're undergoing any treatment, but absolutely with radiation as well. And we don't always know what side effects that you'll have. There's looking at that radiation plan, it can be more common to have some side effects when we know what organs are receiving more dose. But there can be unexpected side effects as well when patients are having treatment. Fatigue tends to be a pretty common side effect among our patients receiving pelvic radiation. This can take a long time to resolve. So generally it's pretty significant during treatment and can persist for a few weeks to even months after. We tell patients to monitor their sleep and anxiety and encourage physical activity. So generally, we want patients to increase their activity as tolerated. And this can be hard to do after treatment. And it's also, important to take into consideration that patients may be receiving other treatment as well. So if you are having chemotherapy or immunotherapy or hormonal therapy, or surgery, that can affect certainly your fatigue over time as well. Loss of appetite and weight loss. Many patients will have a decreased appetite during treatment. We encourage small, frequent meals. If a few weeks after treatment, patients' appetite is not starting to increase, or patients are continuing to lose weight, that's when we would have a low threshold to refer to nutrition to discuss further. Hair loss within the treatment field is also a side effect of radiation. So generally, it would be any hair within the pelvic field. It's not, it's not a systemic treatment. So hair loss on the head is not something you'd expect with pelvic radiation. Of course, that can occur again if patients are on chemotherapy or another treatment, but we wouldn't expect hair loss on the head from pelvic radiation treatment. This can be acute or chronic. Sometimes the hair will grow back and sometimes the hair does not grow back over time. There can be skin changes in the area that was treated as well. So hypo or hyperpigmentation, atrophy or thinning of the skin. The blood vessels can appear more at the surface of the skin, and there can be skin breakdown. Again, we try to address this as it happens during treatment. It's more common for patients that are receiving more dose to the surface of the skin. But we try to give things to lubricate the skin during treatment if needed. And generally, these can be some long-term changes, or it can the pigmentation can come back over time. Rarely we see chronic wound issues, but if we did, we would refer to the wound care clinic, and patients can also use hyperbaric oxygen therapy if that's needed. We encourage sunscreen in the area that's being treated if it's exposed to the sun while the patient is receiving treatment. Lymphedema can also be a side effect of radiation treatment. If this persists over time, we generally refer to the lymphedema physical therapy, and that can be very helpful for patients. Secondary malignancies are extremely rare, but there is a very small risk of secondary malignancies in the area that's being treated by radiation. Generally, if we do see this, it's many, many years post-treatment. This may increase over, next years as we continue to have more long-term cancer survivors. So for gastrointestinal side effects, these patients might have ulcerations. Radiation fields that extend to the upper GI tract can lead to gastritis, so inflammation and ulceration. These can be managed with medical management. We also will often refer patients to gastroenterology, and patients might require an endoscopy or a scope to take a look. Enteritis, this can be acute or chronic. So inflammation in the GI tract. This can cause diarrhea, flatulence, so gas, bowel incontinence or cramping. We can manage this with diet modifications or try some fiber bulking agents. Antidiarrheals or anti-gas medications. We also really encourage pelvic floor physical therapy as an option for patients who are especially having issues with incontinence. Hematochezia, which is blood in the stool. This can be acute or chronic due to damage to the small blood vessels and lining of the rectum or the colon. Hemorrhoids can also occur. So again, we can use medical management for this. We often refer to gastroenterology. And again, this could require a scope as well. That we can also do sitz baths for patients to help with the discomfort. Proctitis, which is inflammation of the rectum. This can cause fecal urgency, incontinence, tenesmus, hematochezia, again, bleeding or discomfort with bowel movements. Again, we can use medical management for this. There are different medications. Again, we often refer to pelvic floor physical therapy for incontinence. And if symptoms are severe, we would refer to gastroenterology. Anal stricture or narrowing of the anal tract there is can cause pain with bowel movements, narrow stools, constipation, or blood in the stool. And again, if severe, we would refer to GI or colorectal surgery for possible surgical intervention if required, or dilation. Cystitis, which is inflammation of the bladder wall. This is damage to the bladder wall and nerves from radiation, which can cause increased urinary frequency, urinary urgency, or spasms. Also could cause blood in the urine. So for this, we can advise patients to avoid fluids before bed, minimize alcohol and caffeine. There are also medications that can help with this. And we do refer patients to urology often, or for some of our gynecological patients, we do refer to urogynecology as well. Urinary incontinence can also be a side effect that can be acute or chronic, can cause urinary leakage. And again, pelvic floor physical therapy can be very helpful for this. Urethral stricture, which would cause difficulty and pain passing urine, or a weak or slow urinary stream, and can have blood in the urine or semen. And for this, we would refer also to urology. So for sexual dysfunction in our male patients, treatment to the pelvis can cause erectile dysfunction and ejaculation or decreased libido. So there are medications we can use for this. We can also refer to the Men's Sexual Health Clinic within the Department of Urology, and there's also a Dana-Farber Sexual Health Clinic. For patients who are desiring fertility in the future, treatment to the pelvis can cause infertility. The management for this generally is prior to receiving treatment. The patients are counseled and should be referred to reproductive endocrinology or Men's Health Clinic in urology to make a plan prior to treatment if they do desire fertility in the future. For gynecological side effects, vaginal stenosis or scarring of the vaginal tissue is a common side effect of pelvic radiation. So this is narrowing of the vaginal canal from fibrosis or scarring of that tissue caused by radiation. This can also cause bleeding when those blood vessels are closer to the surface. For this, we recommend vaginal dilator use or intercourse, and vaginal moisturizers or estrogen. This helps disrupt that scar tissue and prevent it from forming. It can also be helpful for patients to be able to tolerate pelvic exams, which many of our gynecological patients will receive frequently in surveillance over time. Sexual dysfunction can be caused by vaginal dryness or pain with intercourse. We often recommend vaginal moisturizers or vaginal estrogen for patients who are candidates for that. Pelvic floor physical therapy can be very helpful for this, and a referral to the Dana-Farber Sexual Health Clinic as well. For patients who are desiring fertility in the future, again, this is a discussion prior to starting treatment where we can do things ahead of time, like egg freezing. And there is a surgical procedure where we can sometimes move the ovaries out of the radiation field prior to surgery, prior to receiving radiation, which can be effective. Many of our patients who are not in menopause prior to receiving, most of our patients will go through menopause with this treatment, including systemic chemo as well can cause this. So for patients that do go through menopause, hormone replacement therapy can be an option for some patients. There a referral to the menopause clinic at Brigham and Women's, and vaginal moisturizers or estrogen can be helpful as well. And we often recommend DEXA scans to check on bone density. So in the pelvis, when we're treating the pelvis, the bones will get radiation dose as well. So this can cause insufficiency fractures in patients. If a patient is having persistent pain in the pelvis or hip region, this is a good reason to order an MRI and to make sure there's not a fracture there. We do have an ortho-oncology team who can manage these issues, and sometimes it's just symptomatic management and watching it as it heals. From treatment to the bone as well, you can have bone marrow suppression. So one way that we watch this is with regular labs. Most patients who are also on chemotherapy will be getting frequent labs. We can optimize patients as needed. So that means if the labs are going too low, like the red blood cells or the white blood cells, sometimes we'll give patients transfusions if they need them. If the white blood cells are low, we give patients neutropenic precautions during treatment. And that is just to prevent infection. So like, for example, wearing a mask in a public or busy place. And this generally resolves when the treatment stops. It will resolve over time. If this continues to be a chronic issue and the labs are not resolving, we would refer to hematology. So there's different types of radiation, and some of these radiation modalities can be used to minimize dose to surrounding tissues. So here are a few examples of these types of radiation that can be more targeted to the area that we're trying to treat. Depending on what we're treating and why we're treating it, these aren't always options for all of our patients. Sometimes depending on the where the disease is or what areas, if we're trying to treat surrounding areas, these modalities are not great options. If they are, typically this is a conversation with the patient and the radiation oncologist to decide what is the best treatment for them. But some of these treatments can be very effective at reducing side effects when we are really just targeting one specific area. Another way that we're minimizing dose, this is something that myself and Abby have been working on here, and we just started doing this about a year ago, but some of our patients will use a vaginal dilator during treatment for if they're receiving treatment for colorectal cancer. This helps actually push one of the vaginal walls away from the treatment field and can reduce sexual health side effects in the long term. So we're always trying to do what we can to reduce these side effects as long as the patients are receiving appropriate treatment while we do that. This is another example. This is called a space OAR. This is something that is sometimes used in prostate cancer. So this is a example of prostate cancer treatment. And this is a hydrogel that goes in between the prostate and the rectum, which can be inserted in reduced dose to the rectum when appropriate. So, screening patients for chronic side effects. So, it's really important to talk to your provider about any adverse effects. A lot in follow-up clinic, we see, we can ask specific questions and say, are you having any diarrhea or urinary symptoms, bowel changes, etc. And oftentimes patients kind of brush over it because sometimes it's survivor guilt, or they just wanted, the goal, of course, for them was to be disease free. And if they are, they don't want to complain about side effects. And really, as providers, we really want your quality of life to always be as optimal as possible. So we always want to hear if any side effects are going on. It's important to report side effects because the other reason is that we always want to be able to rule out any disease recurrence if you're having any side effects. And we want to be able to manage the side effects that are going on. So your quality of life is very important. And as we talked about, there's a lot of resources that are available to you, medications, referrals, more imaging, things to do when you're having these symptoms. So we want to know about them. And so in summary, acute and chronic radiation side effects are often correlated to how much dose the patient received in the area that was treated. We have evolving strategies and technologies to minimize the dose to the surrounding tissue and reduce the side effects. And I'm sure in the future we'll have even more and hopefully be able to reduce those side effects even further. It's critical to report any issues that you're having as a patient and for providers to be able to manage these symptoms and refer out when necessary to try to make your quality of life as good as possible. So we always just emphasize your quality of life is extremely important, and we want to do whatever we can to make that better.
Thank you so much, Betty, for that wonderful presentation. As I mentioned earlier, everyone, this session was recorded and it will be posted on our Blum YouTube playlist in our Blum Digital Resource Center and also the Survivorship website. We are all set. Thank you, everyone, for joining, and thank you so much, Betty, for presenting today.